Hi everyone, welcome to ACB webinar and for this evening. I'm Su-Lei Yin, and so I'm one of the medical oncology registrar and from Cambridge University Hospital. I'm currently SD5 and doing a renal melanoma tumor site rotation. And we have two fantastic speakers for this evening webinar, and so urology, so it's mainly in bladder and renal cell cancer. I have two fantastic speakers. So it's Dr. Will Ince, and who will cover the bladder cancer, and Dr. Kate Fife, and so who will cover the renal cell cancer for the second part of our webinar. So first of all, and I want to introduce our first speaker, Dr. Will Ince, and who is a consultant oncologist in Cambridge University Hospital. So, and who is trained in St. Bartholomew Hospital and completed postgraduate training in London and Cambridge. So who is currently specialized in urology and renal cancer and head and neck. And so I will hand it over to Dr. Ince and for our first part of the webinar.
Many of you will have done a urology job where you'll either see patients in a general urology clinic or uro-oncology clinic. Some of you will have done a bladder-specific job or a urothelial-specific job, and some of you won't yet have come to uro-oncology. So I've tried to keep it sort of fairly broad to give everyone an equal understanding of things. And there may be people who have done PhDs in urothelial cancer and those sorts of things, and for them it might not be quite as in deep as they would like, but I'm going to try and cover quite a broad range of things, and if people do have questions, then please do put them in the chat. I'm going to talk a little bit about sort of where we are, and often I try and think of urothelial cancers as sort of trying to work out where you are in the patient's disease journey, so where they are, what biomarkers you've got available, and what chemotherapy or immunotherapy you can use, and both of those things are slightly not without controversy when it comes to biomarkers in particular, and I'll touch on that recurrent theme throughout the talks. I'll go over the neoadjuvant space, the adjuvant space, and also come on to the metastatic setting as well. Aaron's already got his hand up. I don't know if that's a mistake, but if you do want to ask something, Aaron, then just pop it in the chat. I can't see the chat at the moment, so Sue, if you can see it and keep me posted, that'd be good. And then any sort of future considerations that what's coming around the corner for the clinic and systemic practice. So I'm not going to cover, but they are important. I'm not going to talk about the non-urothelial cancers. That's the squamous cell cancers and the small cell cancers that make up probably about 10% of the bladder cohorts that we see. I'm not going to cover upper tract urothelial cancer, though it does creep in a little bit. There is a sort of debate that's ongoing amongst the community about how you definitively treat these people. So is that cystectomy? Is it something called trimodality treatment with TURBT drugs and radiotherapy, or indeed just drugs alone with chemo IO? So, but I'm happy to answer any questions people have on that particular thing. I'm going to talk a little bit about bladder sparing, but again, it comes into that definitive treatment debate space. So it's important to have a reasonable understanding of staging. When you're at your MDTs, and bladder MDTs tend to be quite a war of attrition, but as soon as you hear the letter T and the number 2 said together, you should probably just sit up for a minute and start listening. TA and T1 are not really something that we're involved with in a huge amount at the moment, though non-muscle invasive bladder cancer, to which those refer, is something that we are starting to become more involved with, though that's only in experimental trials at the moment. Node positive bladder cancer is really incurable as per the paradigm, though there are people who treat these quite aggressively. So essentially, muscle invasive bladder cancer is where we start to get interested, and within that we need to think about our biomarker. I said we're in the muscle invasive space, so what are our biomarkers? And really in this setting, it's why we give neoadjuvant therapy as opposed to adjuvant therapy. And the biomarker here is how much complete response you can see in their post-operative histology. So I quite like ESMO as a guideline issuing body. There are others. We have NICE in the UK, but they sometimes get a bit sort of inaccurate because of our CDF rules, and America have the NCCN. Europe also have EAU, and I make some reference to the EAU guidelines, but I think the ESMO guidelines for urothelial cancer are a pretty useful resource by which to go by. So it looks fairly straightforward there. You have to judge if they are fit for cisplatin or not, and there's this cisplatin eligibility criteria that are there on the left. They were developed by a chap called Matt Galsky, who's a pretty well-known bladder oncologist from the US, and he developed these cisplatin eligibility criteria based on the metastatic disease setting, but they also hold weight within the neoadjuvant and adjuvant space. So it's important to think about those things as well. So in terms of what we do, if you come to the clinic with a bladder cancer or a urothelial cancer in the bladder that is eligible for cisplatin, you get cisplatin-based chemotherapy. Cisplatin-based chemotherapy comes in two guises, essentially. There is gemcitabine and cisplatin, and there is dose-dense or not dose-dense MVAC. In terms of the biomarker we're looking for, it's that PT0 at cystectomy. There is no randomized evidence that suggests that carboplatin has activity in this setting. So in terms of the options in this space, they really lie between GemCis and MVAC. I don't use gemcitabine and carboplatin. I don't think it's active enough neoadjuvantly, and I worry about these people not getting to cystectomy. And on this slide, there are a number of pieces of information about the rates of complete response. So you're really left with, as I said, that option between, I'm just going to slip through this slide, between whether or not to give dose-dense MVAC or gemcitabine cisplatin. As a general rule from this ABC meta-analysis, and this is what often people say in the clinic, we think neoadjuvant chemotherapy offers a 5% absolute increase in overall survival at 5 years. And that's quite important. That's probably an important figure to take away. And that seems to be the case across radiotherapy and cystectomized patients based on this very old but quite robust meta-analysis from the Advanced Bladder Cancer Consortium. So I talked a little bit about whether or not to give dose-dense MVAC or cisplatin and gemcitabine, and for many years it was a bit uncertain. However, recently the French group, the JETUG group, published their VESPER trial, which suggests that the rates of PT0, which we are using as our biomarker in this space, are significantly, and I mean that statistically, higher with dose-dense MVAC. Now, you have to think about what the patient stood in front of you is able to tolerate, and dose-dense MVAC has got 4 drugs, including an anthracycline. Gemcitabine cisplatin is only 2 drugs. So you are substratifying people into patients who you think are able to cope with dose-dense MVAC. And it's an important thing to think about. But we think the best outcome is delivered by dose-dense MVAC, followed, and probably pretty closely, if I'm honest, by gemcitabine and cisplatin. But the number of cycles matters. So there's sometimes debate about whether or not to give 3 or 4 gemcitabine cisplatins or 4 or 6 dose-dense MVACs. But we know that the median total dose of cisplatin was higher in the MVAC arm, and the proportion of patients who got a pathological CR was higher in that too. So I think the number of cycles matters, and the amount of platinum you get in matters. So just to summarize that bit, as I said, it probably goes along the lines of dose-dense MVAC followed by gemcitabine and cisplatin. If you have a patient whose creatinine clearance is the only thing stopping them from getting chemotherapy, then I sometimes use split dose cisplatin. So you split the dose of cisplatin on day 1 and day 8. So you give the GemCis at those on those days, and there is good evidence that that has a similar effect to 3 weekly cisplatin. I don't give carboplatin, but there are centres and oncologists in the UK and abroad who definitely do. So I'm happy to discuss that with people who have experienced that. So we're sort of in a setting where approximately 40% of people still will recur in spite of that. And we are continuing to think about perioperative immunotherapy. You'll all be familiar with immunotherapy, and many of you will be familiar with it in the space of bladder cancer. So there have been a number of trials in this space, though it's not licensed in any setting yet, but trials are ongoing. Largely, it's not been that much better than dose dense MVAC. If you see there, the pathological complete response rate, the PT0 rate, which is our biomarker in this space, has a rate of 36% or so with MVAC in the VESPA trial. It's not hugely better across the board. There are some, that NEMIO and HCR and GCP, but numbers were relatively small, and trials are ongoing. So again, watch this space. But at the moment, all we have is neoadjuvant chemotherapy, and these are some of the ongoing trials that I talked about. So we are continuing to think about the cis-ineligible patients in this cohort and trying to escalate those in the cis-eligible cohort. But I think these slides will be available just to keep you in the loop as to what's happening. So why do we give neoadjuvant chemotherapy? Because it gives us a quick and nice answer. You're giving it to probably cells that are chemo sensitive at that stage, and it aims to treat all micrometastases as well. So I suppose that the adjuvant space is something that we've also looked at. There are no randomized trials comparing neoadjuvant with adjuvant, but sometimes patients do ask about it and surgeons do ask about it as well. Like I say on this slide, there are pros and cons to adjuvant chemotherapy and neoadjuvant chemotherapy, but the main one really is that a cystectomy is a massive operation, and there are nuances to doing pelvic lymph node dissections as well. And many of these patients afterwards will not be fit enough in their first 12 weeks to receive adjuvant chemotherapy, and various trials have estimated that at about a third of patients. So it's best to get chemotherapy in early doors. Irrespective of the success of neoadjuvant chemotherapy, and I quoted it, there are still a big chunk of patients who will recur, and they will recur in an incurable space. So essentially, we need to think about whether or not there are better things we can do. And I talked about IO in the neoadjuvant space, but it's causing more excitement in the adjuvant space. As you can see there are 3 big phase 3 trials that have looked at this, Ambassador 274 and 010. 2 of those have been positive for DFS. InVigor 010 is interesting in so much that it stratified people according to their ctDNA profile, and I'll come back to that a bit later. But essentially, we are left with adjuvant nivolumab, adjuvant pembrolizumab, and adjuvant nivolumab, the trial is the 274. So when I talked a moment ago about the ABC of bladder cancer, so now we're in the adjuvant space, so that biomarker of complete response no longer exists. So we have to think about other biomarkers, and it brings me on to the PD-L1 biomarker in bladder cancer, which is not very good and not very helpful either, particularly predictively. If you look at that slide on the left, this is the ITT population, so all comers, and it has an effect across the board, as you can see there, improving DFS significantly. In the PD-L1 greater than 1%, and this is CPS, for those of you who don't know, in the bladder cancer cohort, it works. You could argue it works a bit better, but I think that the FDA, NICE, the EMA have approved it in different settings. So the FDA allow it for all comers, the EMA and NICE and the CDF only allow it for the PD-L1 positive tumor group. And I think on the basis of those curves that you can see, we may be disadvantaging a subset of patients. Recently at the EAU conference in April, they published their overall survival advantage. So there is an overall survival advantage across the board for adjuvant nivolumab in high-risk muscle-invasive bladder cancer. And as you can see, again, it seems to be slightly more pronounced in the PD-L1 positive cohort, but retains a degree in the ITT group. And finally, pembrolizumab in this space, I talked about it having a DFS advantage, and that's illustrated there. Again, we have gone by the PD-L1 biomarker, but if you will see on the left is your CPS positive group, and on the right is the PD-L1 negative group, and it seems to have more of an effect in the PD-L1 negative group. But that was different to the Nivo data, and there's no overall survival advantage to Ambassador. So it's all a bit of a mess in the adjuvant space at the moment. We have adjuvant nivolumab, but PD-1 inhibitors across the board otherwise have not seemed to have much activity adjuvantly, which is interestingly quite similar to the renal story that you'll hear from Kate in a bit. Right, I'm going to give a break there. We've done neoadjuvant, we've done adjuvant, and I think we're just about to time. But I'll move swiftly on to metastatic disease and probably take some questions at the end if people want to. So again, we need to think about where we are. So that's in the metastatic disease space and what our biomarkers are. And there are a plethora of biomarkers potentially now, both predictive, predominantly allegedly predictive, but also prognostic. And thus you need to think of your chemotherapy and systemic therapy. So we've had many years of platinum-based chemotherapy. This was a trial in the earlier part of this century, right at the beginning of this century. But in essence, we've been using gemcitabine and cisplatin in this space for over 40 years, for longer than I've been alive. We'll remember those eligibility for cisplatin, and we think about half of patients are not eligible for cisplatin. This is a different setting, so we would want to treat them with carboplatin if possible. So does it matter? Often some people say, well, they've all got metastatic disease. I just give gem carbo. I'm not going to bother giving them cisplatin. They're not in the greatest of shapes. But essentially, it does look like cisplatin is more active in this space than carboplatin. This is illustrated on the next couple of slides. The other important thing to bear in mind is that cisplatin, after treatment, leads to induction of a gene expression that appears to be more immune sensitive. So I'm going to talk a little bit in a minute about what we do after chemotherapy, but that is an important thing to bear in mind, that signaling pathways are modulated by chemotherapy, and that's seen across the board in lung cancer and other bits and pieces as well. So we know that chemotherapy is active, GemCis is active, MVAC seems about as active as GemCis in the metastatic setting. What about single agent IO? Well, it's less exciting up front, as you see there. Many of the licensing trials have tried to look at IO monotherapy, IO chemotherapy, and chemotherapy alone in this space. And it's not been quite the panacea that we were perhaps hoping for. But this slide just shows the main trials in this space, looking at that, looking at Atezo, Pembro, Atezo a couple of times in Durva. So I talked about the ESMO guidelines being quite useful. This is the ESMO guidelines as was in 2022, and it's important to reference 2022, and I'll come back to that in a minute. But essentially, you've got three groups: cisplatin eligible, ineligible, and ineligible, and PD-L1 positive, and that's what they get. And this is still very applicable in the UK. Afterwards, if there's response or no progression, you get maintenance of avelumab after chemotherapy, and maintenance of avelumab probably improves your overall survival by about 6 months medianly. In terms of if you are cisplatin ineligible and PD-L1 positive, you can start with first-line atezolizumab, or indeed come back to that if you progress on chemotherapy. It's not a great thing that people respond to, but it is an option there. So many of you will be familiar with the data presented at ESMO last year by Tom Poles regarding EV and Pembro. So those were the guidelines that I just showed you. And this was the paper that he presented at ESMO. So an improvement in overall survival in the ITT group from 44% to 70%, and he got a standing ovation at the plenary. So it's really changed our options in the first line. And that's what it looks like now. It's much better. Everyone gets EV Pembro if they can, and then you move on. So that it's much more straightforward, the ESMO guideline that was. In terms of where we are now with metastatic bladder cancer options, there are a plethora of things. I talked about first and second line immunotherapy a minute ago, and I've also mentioned this drug, EV, enfortumab vedotin, which is an antibody drug conjugate. Many of you will be familiar with what antibody drug conjugates are, but they have a target, and with that target, they introduce cytotoxic chemotherapy intracellularly. So we are really at the stage where we have some better drugs and biomarkers remain a problem. So EV targets something called Nectin-4, which is very plentiful in bladder cancer. So the ADC targets that we're talking about include these ones here. So there are a number of biomarkers that seem active in bladder cancer. Having said all of that, when you think about biomarkers and late disease, you also need to think about what your drug available is. So for example, in later line disease, we have a drug called erdafitinib. And erdafitinib targets FGFR. This thing here it's a TKI, it's a very potent FGFR inhibitor, and about 20% of patients express this. So it has been used in trials. This is the Thor trial, looking at locally advanced second or metastatic second line therapy. So these are those that have had prior PD-L1 or no prior PD-L1, and they are stratified according to that. And if you see here, in that group, in the group that are FGFR positive, they do less well with erdafitinib. Despite being positive for the biomarker, they still do better with Pembro. So why is that? We don't fully understand. Is it a great biomarker? Probably not. But biomarkers, as I said, are a problem in bladder cancers and urothelial cancers generally. So this is just the results of the second line EV trial. At the moment, we think we're going to be using more EV Pembro up front, and thereafter come back to chemotherapy as a second line. So essentially, the future looks like many more of these ADCs. I've already shown this slide, and there are antibody drug conjugates that target these things. So if you look across the board here, we're particularly excited about HER2 and TROP1 at the moment. They're mentioned in this slide again. TROP2 and HER2. And so we know how much is expressed in bladder cancers generally. So probably about 40% of all bladder cancers express HER2, and we can target that with various novel ADCs. So you'll all have heard about trastuzumab deruxtecan, which I think they're using a lot more in breast cancer these days. And it's important to note how much HER2 it expresses, so what your IHC plus is, so 3 plus and 2 plus, and how much of an effect that has on things. So again, we thought if you have 3 plus, you're going to do a bit better than 2 plus. But again, in these early stage trials, early phase trials, that doesn't seem to hold water. In terms of other ADCs that are being investigated at the moment, there's the Trophy trial looking at sacituzumab govitecan across a number of different cohorts, and we've had various ones of these trials open. So essentially, this is where we are at the moment. We have in the UK, we have cisplatin eligible, carboplatin eligible, and the chemotherapy ineligible patients. In Europe, in the US, they give everyone who can have it EV Pembro because it improves survival from 44% to closer to 70%. But we use maintenance avelumab, and on disease progression after maintenance avelumab, the options in the UK are limited to second-line chemotherapy or trials. But it's important as an oncologist to be aware of what's coming through, what the future might look like, and it's likely at the point of progression on um, uh, immunotherapy after GEM-CIS that you're going to be thinking about biomarkers. I haven't included the paper about GEM-CIS and NIVO, which is an important one to read as well. So I think that's about it. I've sort of tried to cover the full raft of bladder cancer there quite quickly, and here sort of describes what the next set of trials will be looking at and what the questions we need to answer in bladder cancer are really. But it's particularly around biomarkers, sequencing, and combination therapies, and where they best sit.
I have one question. So, how would you choose and for the neoadjuvant treatment? Is it neoadjuvant chemo versus immunotherapy?
So neoadjuvant immunotherapy is not licensed, so we don't really have that problem at the moment. And I think generally the sort of decision in the neoadjuvant space is really one of whether to use dose-dense MVAC or gemcitabine and cisplatin, and that sometimes is sort of dependent on your threshold. I use a lot of MVAC, a lot, and I think it's important for those of you who do want to be uro-oncologists to get used to your neoadjuvant regimen and use it as much as you can, really. I think if you only use dose-dense MVAC once a year, you're probably not getting used to it enough and are a bit scared of it. And I suppose it is slightly scarier to be giving 4 drugs, but
Yeah.
I've not had any really massive serious events. But I think that's just about picking your patient cohort, and the patients that we see in Cambridge may be different to Glasgow or Plymouth or London or those sorts of places. But yeah.
Okay.
Does anyone else want to ask anything? Or have you all been
Any questions and from
in?
audience? Yeah, so in one question's come up. So for adjuvant nivolumab, and is it only patients who do not have complete pathological response and are PD-L1
Really good
that get it?
question. So yes, essentially it is. So you want to be ET1 or more in the post-operative histology, and it's only those who have PD-L1 positivity. As I said a number of times in the talk, I think PD-L1 is probably the wrong thing to look at as a biomarker. This is just sort of academic discussion. You have to do it in terms of the reality of life. But there are trials. So there's the InVigor, I think it's 11 or 12, that's being led by Tom Poles nationally. That's looking at stratifying patients according to their ctDNA afterwards and giving them atezolizumab based on their ctDNA profile rather than just their PD-L1 status. I don't think PD-L1 is the right route to go down, but standard of care is yes. If you have residual disease after a cystectomy, give adjuvant nivolumab. Yeah. That's probably about 50% or close to 60% of patients who have some residual disease in them.
Right. Oh, there's one more question's come up. When is EV Pembro coming? And now there is an overall survival benefit, and presumably we will have soon.
Yeah, see, I'm not. I think that's a very good question, Claire. So the trouble with EV and Pembro is that they are made by two different companies that require negotiation with the reimbursing authorities, and in addition to that, EV is very, very expensive. So I've had some private patients on it, and I don't think they'll be getting their premiums replaced next year, putting it mildly. But I would say that I'm worried that it might never come. Is how I would say it on the noises that I have heard. But it's being negotiated hard at the moment between the powers that be. Yeah, but I think the OS benefit is so striking that it's something that patient groups will really knock on the door of. But fortunately, bladder cancer is a relatively rare cancer, so it doesn't quite have the lobby of other cancers. I hope that answers your question.
Great. And so a matter of time, and thank you so much, Will, for
No,
accepting my invitation. All
no
right.
worries. Fine, great. Thank you, Sue.
Thank you.
I'm happy to stay on if people have other questions, but yeah,
Sure.
I
Yeah.
will hand the floor to Dr. Fife.
Right. So I would like to introduce the second speaker and for to cover the second part of our ACP webinar today. So, and Dr. Kate Fife is a consultant oncologist in Cambridge University Hospital and has been appointed since 2001. So, and she qualified and from St. George, London, and trained oncology in Royal Marsden, Imperial, and Sydney. And so she is currently specialized in kidney and skin cancer in Cambridge University Hospital, and she's very active in involving clinical and translational research as well. So I will hand it over to Dr. Fife to cover the second talk.
Lovely. Thank you very much, Sue. And thanks, Will, for that enlightening talk. Well, thanks, Sue, very much for asking me to talk this evening. I'm going to talk about the fascinating world of renal cancer. Renal cancer is about the sixth or seventh commonest cancer in the UK. And the peak, so the incidence is about 12,000 cases a year. And interestingly, about a third of our patients are aged over 75, but the median age is in the sort of mid to late 60s. But as you can see, it can occur at any age. The other thing to note is that when the primary tumour reaches 4 centimetres or greater, the risk of developing metastatic disease and therefore a far worse outcome is significantly higher. Is one of the cancers that's increasing most, more than sort of any other cancer virtually, and there's projected increase over the next 2 years of 10 years of 25%. Quite a lot of these patients are diagnosed incidentally. Oops, to that slide. So I'll just get all of this up. So 80% of renal cell cancer, clear cell, no, 80% of kidney cancers are renal cancers. You occasionally get sort of urothelial cancers, obviously affecting the renal pelvis. You can occasionally get renal lymphomas, and the vast majority of the renal cancers that we see are renal cell carcinomas are clear cell, about 75 or 80%. We do get a number of non-clear cell. Papillary is the most common at 10 to 15%, and chromophobe less common at 3 to 5%. So both papillary and chromophobe tend to have a lower rate of metastatic disease. So if they are fully excised, they have a lower risk of developing metastases in the future. This risk factors include smoking, obesity, and hypertension, but we get a lot of thin non-smokers as well. Hypertension is really seems to be quite strongly associated with developing kidney cancer. We don't quite know why, and also chronic kidney disease. There's genetic predispositions with von Hippel-Lindau syndrome and various other rarer predispositions syndromes. The classic presentation is with blood in the urine, but really these patients are the lucky ones because they're often diagnosed at a relatively early stage. Flank pain can happen when your tumour's a lot bigger, and certainly with metastatic disease, paraneoplastic phenomena are really common. Things like hypercalcemia and night sweats, weight loss, anemia, occasionally polycythemia. All of these things can indicate metastatic renal cancer. So obviously we look at CT scans, MRI scans, and very, very importantly, particularly in patients with metastatic disease, we do need to have a biopsy before we institute treatment, as demonstrated beautifully to us last week, when one patient that we were convinced had metastatic renal cancer with hypercalcemia, weight loss, etc., turned out actually to have a renal lymphoma, which took us all by surprise, but these things happen, so that's why biopsy is so important. When we're talking about early stage kidney cancer, there's a phenomenon really called small renal masses, which are usually small tumours less than 4 centimetres, frequently an incidental finding, and you'll find that your MDTs get full of these patients referred from other specialties. So treatment options for these are surveillance. They can have ablation, which can include cryoablation or radiofrequency ablation, microwave ablation, partial nephrectomy, and hopefully coming to a hospital near us soon will be SABRE, which is an extremely effective treatment for primary renal cancers. Ablation is limited in terms of the size of the tumour, so usually a maximum of 4 centimetres, and also the proximity to the collecting system, because you can get nasty urinary leaks and things if you use RFA in tumours very close to the collecting system, whereas SABRE doesn't have those issues. If you resect these, some of them will be benign, have variable natural history, which is why it's actually that we're increasingly doing biopsies on these tumours. And obviously, if it's something benign, then they don't need prolonged follow-up. But if it is, they can choose active surveillance or resection, and often the surgeon will put that option to the patient. So here are the options for different stages. So as you can see in stage 1, you can have cryotherapy or radioablation or nephron sparing surgery, which is limited a little bit by the location of the tumour. If the tumour's right in the middle of the kidney, it's a bit harder, and also the tumour has to sort of distort the sort of capsule so that they can find it properly when they're doing their partial nephrectomies, robotic partial nephrectomies. That's all. Nephron sparing surgery can also be used in stage 2 cancers as well, but that is really dependent on the size and location. Radical nephrectomy, of course, is suitable for all stages, including some stage 4 cancers, which is an area of controversy at the moment. These are the most common metastatic sites. So on the left-hand side, you've got all comers. So the commonest is lymph nodes and lung, and then liver, bone, liver, and brain. Look on the right-hand side, that's patients presenting with a solitary site of metastasis. So most commonly lung and around 10% bone. I've just for sort of relief, really, I've put in these pictures. This is what we typically will see in our clinic. This is a chap who's 56 years old when he presented, very, very fit, runs 40 miles a week, no risk factors, never smoked, and he actually presented with focal seizures and was found to have 3 brain metastases, lung metastases, and a renal primary, and proved to have clear cell cancer. But this sort of presentation is not uncommon. He went on to have SRS to those vein lesions and then systemic therapy. So there's a number of different molecular pathways which are important in our treatment options. There's the mTOR pathway, which we'll touch on later, VHL pathway, which is exceedingly important, immune dysfunction as well, and immune infiltration, and metabolic dysregulation, which is important in some of the inherited syndromes, such as the FH mutants. A lot of these patients will have loss of chromosome 3p, which includes a lot of the extremely important genes in the genesis of renal cancer. This is how our anti-angiogenics, this is how our anti-angiogenics work here. So these are a number of the anti-angiogenic TKIs. and they're actually predominantly working on the endothelial cells themselves. So they usually target many tyrosine kinase inhibitors, up to 70 or 80, predominantly VEGF, vascular endothelial factor receptor, and to a certain extent PDGF, and there's a number of other targets which vary according to your according to the TKI. Bevacizumab, which is not used commonly now, is actually a VEGF antibody, and then here we have the action of everolimus, which acts on the mTOR pathway and affects both the metabolic response of the cell and also the HIF pathway. So additionally now, I haven't got it on this schema, we do have HIF2 alpha inhibitor, belzutifan, which I'll mention at the end. So this is the, I don't really need to tell you all how immunotherapy works, but it has proven to be very effective in kidney cancers and very important new treatment. This is some fantastic work that I'll it's just shown a couple of graphics here, but do look it up. The TracerX study with Samra Turelik's group, which shows the evolution of all these genetic changes and how you can get, you have your VHL mutation, then you get a number of other mutations which can affect the behavior of the tumor, and also single cell transcriptomes here, which have been done by Tom Mitchell at the Sanger. So there's some interesting background science which will eventually lead us on to better treatments, but it's well worth having a good read of. So we then look at, we're moving on to treatment now. So we have done a number of adjuvant studies over the years, initially with interferon and the old immunotherapy, and then with sunitinib and sorafenib and so on. And there was basically no disease-free survival benefit for any of these treatments, although there was some PFS benefit with the sunitinib study. However, obviously none of these have been taken on as treatment. So there's been a long search for adjuvant treatment. This is a risk system. There's a number of different risk systems, but this is one that we use quite regularly, which is called the Leibovitz score, and you can score from 0 all the way up to about 12, 13, I think, depending on various histological factors of your tumor, and that this is quite old data now, so I think generally the outcome's probably a bit better, but you can see that that there's a gradation in the risk of metastases up to very, very high risks. So this is used in assigning the postoperative follow-up, and also now we are looking at adjuvant immunotherapy. So there have been a number of studies. I'm going to go through the one that is the most important one that our current treatments are based on, and this is the Keynote 564, patients with clear cell renal cancer, no prior systemic therapy, stratified. So they received either pembrolizumab 3 weekly for a year or placebo, and the groups were defined as mainly their M0, but there were some patients with M1 disease that was completely resected within a year of diagnosis. Primary endpoint was DFS per investigator with OS as secondary endpoint. These are quite important to know because these are the pre-specified risk categories, and this is what we base our current treatments on. We've got the intermediate high risk patients. So T2 patients are only included if they're grade 4 sarcomatoid, any T3 and any T4 and any node positive patients. So those are the ones that are eligible for adjuvant pembrolizumab, and also ones M1 with no evidence of disease, but again that's an area of controversy. This is the disease-free survival in the intention to treat population. So I'll just go back to that. So this is the primary endpoint, which was met with a hazard ratio of 0.72 after median follow-up of 57 months. And you can see it was a 2-to-1, so that the absolute difference in disease-free survival is around 8 or 9% at 2 years, 4 years, sorry. This is the overall survival. So this is a fairly recent development. We now have a definite overall survival benefit, which is the first time in kidney cancer. So again, the absolute benefit, if you look out here, is relatively small, but still there is a significant improvement with a hazard ratio of 0.62. This is looking at the different risk groups. So the higher your risk, the greater your benefit, and lower the hazard ratio. So in the intermediate high risk group, hazard ratio 0.68. In the high risk group, we're looking at hazard ratio of 0.6 with a proportionately bigger greater benefit. There's seems to be a very large benefit for the M1 NED, but I say this is an area of controversy because you may think actually we're just undertreating metastatic disease and the patient should be having combination therapy. There were a number of other adjuvant studies. I won't go through in the detail, but it's important to know that actually the other ones were negative. There was the one, sorry, here we are. So I have to keep moving this little thing around. So atezolizumab, that was had a hazard ratio of 0.93. There is quite a lot of discussion about that PD-1 inhibitors seem to have better results than PD-L1 inhibitors in renal cancer. So atezo has been used both in the adjuvant setting and also in a metastatic disease, and it's the only one of the combination therapies that has not shown any overall survival benefit when combined with bevacizumab. With nivolumab and ipi-nivo, interestingly, there was no significant benefit. It's thought possibly that is because it was a 6-month duration of adjuvant treatment as opposed to the year with pembrolizumab, but it's still a little bit difficult to explain these. But because the pembrolizumab study was so sort of, definitively positive, that's what most of the guidelines, including NICE, are based on. So if we look at treatment of advanced disease, the angiogenesis pathway is extremely important, and VEGF targeted agents are often very, very effective. This is the original study showing the efficacy of interferon, sunitinib versus interferon. The IMDC score is really important to know about as well. So this is also called the Heng score after Danny Heng, who formulated it. And this governs our treatment at the moment and which treatment patients are allowed to have according to the Cancer Drugs Fund. And these are less than a year from diagnosis to systemic treatment, by which is meant the time from the very first diagnosis of kidney cancer. So even if they had a primary sort of 5 years ago and then have metastatic disease, then that is obviously more than a year. So it's the very first diagnosis of metastatic of renal cancer. And also the thing about the systemic treatment, obviously that's a slightly movable feast depending on when you decide to start your systemic treatment, because certainly historically a lot of patients, especially with good prognosis disease, have been under surveillance. KPS less than 80, raised calcium, low HB, raised platelets, raised neutrophils. So you add those up and you get your risk group: 0 for favourable risk, 1 to 2 for intermediate risk, and 2 or greater, more than 2 for poor risk. Now, of course, we're also using immune checkpoint inhibitors, and we're using combinations of immunotherapy and angiogenics. So we can either use ipilimumab and nivolumab, which is indicated in intermediate or poor risk, and also we've got lenvatinib, pembrolizumab, and nivolumab, cabozantinib. There are other combinations. If you're listening from in Scotland, then you also have access to axitinib, pembrolizumab. In all risk groups, you can, at least according to the Cancer Drugs Fund, you can use avelumab and axitinib. This is the ipilimumab and nivolumab data. This is the 4-year follow-up, and I think what excites renal oncologists about this is the sort of long-term responders and the flattening off of the curves in the ipi-nivo group. This is one of the combinations that we frequently use, lenvatinib, pembrolizumab, and you can see an improved overall survival versus sunitinib. And I'm going to show you some charts of these as well. So this is the Checkmate 214 study, which is ipi-nivo, Keynote 426, axi-pembro, Checkmate 9ER, cabo-nivo, and Clear len-pem. So they all have sunitinib as a comparator arm, and you've got the various hazard ratios for overall survival there. So Checkmate 214 is 0.69. The PFS is sort of much more similar in the ipi-nivo versus sunitinib. That's because a lot of patients don't necessarily have their response early on. You've also got to look, when you're looking across trials, which you're not meant to, you've really got to look at the prognostic group criteria. As you can see, Keynote 426 and Clear Cell both had, and the Clear trial both had around a third of the patients were favourable risk, which is going to give them better overall PFS. So here are the these are the studies again, just to show you which ones have been carried out recently. So you can get very, very deep responses and very, very effective treatments with the combination of IO and TKI. And this is really important because with ipi-nivo, you tend to get, you have a sort of drop off in PFS in the first few months. And if you have patients with very high volume, very high risk, very aggressive disease, who look like they're going to be sort of failing very, very soon, then using the combination of IO-TKI is more appropriate probably than using ipi-nivo, although with ipi-nivo we do have that long-term potential curative benefit. I'm just going to go through this fairly quickly. So I think we're a bit short of time now, aren't we? This is quite interesting. You can see that the hazard ratios for overall survival with the axi-pembro started off about 0.558, but it has gradually come up towards 1. The same with len-pem and cabo-nivo, probably to a slightly lesser extent, and this is the duration of follow-up. But with ipi-nivo, the hazard ratios remained pretty static, and that sort of reflects the fact that the curves are staying apart. Ipi-nivo is particularly important for patients with sarcomatoid cancer. This is intermediate and poor risk patients with sarcomatoid renal cancer, and a massive difference, and clinically very significant difference in overall survival. We're now getting about half these patients into really good responses, whereas they used to have a really abysmal outlook. So it's really important that patients have got sarcomatoid change that they have immunotherapy. What about adding adding immunotherapy, adding a TKI to ipi-nivo, and this has been done in the COSMIC 313 study, where they randomized patients to placebo or cabo in addition to their ipi-nivo. So they did get an improvement with PFS, but interestingly, this was mainly evident in the intermediate risk population rather than the poor risk population, which may be related to the fact that the poor risk patients are less likely to have very angiogenic disease. So this has not gained approval as yet, because I think because of the discrepancy between the groups and because of the not huge difference between the two groups. These are the current ESMO guidelines. They change quite frequently, so you can look those up. We in the UK don't have access to a PD-1 inhibitor for good risk patients, which is a bone of contention, because the PD-L1 inhibitor, avelumab axitinib, is the only one we have access to, which is not actually even on the guidelines, the ESMO guidelines. Just very briefly mention belzutifan, which is a HIF-2 alpha inhibitor, and very, very high responses in patients with VHL-related renal cancers of about 49% and about 0% progression, and also their retinoblastomas and PNETs improved as well. So that's now approved by the FDA, but not yet in Europe. And we did a phase 3 randomized study of belzutifan against everolimus in patients who previously had checkpoint inhibitors and angiogenic inhibitors. We got superior PFS and superior overall response rate. Not totally stunning, but it's a very, very important development, and probably will be better off used earlier in the pathway for kidney cancer, and there's ongoing clinical trials looking at that as well. Very briefly mention non-clear cell cancer, because I've ignored it and most of the trials ignore it. There's a very good study called B61, in which they showed a response rate of 51% in patients with treated with pembro and lenvatinib. Importantly, also for patients with chromophobe cancer who didn't benefit as much, but still had some reasonable benefit from it.
Thank you so much, Dr. Fife, and that's very fantastic. There's no questions coming up yet. And so I have one question, and for advanced renal cancer, so and with the intermediate or poor risk, so and we normally start an IO-TKI combination. So if the patient progress, and would you just go for the second line as a TKI alone, or are we allowed to use the other combination of the IO-TKI?
No, we're not allowed. And also it seems to be that immunotherapy upfront is the best. It's the best time to use it. So your best chances initially. There've been a couple of trials or 3 trials, I think, in which they've looked at if patients have progressed on nivolumab, they're adding in ipilimumab rather than using ipi upfront to try and reduce the toxicity. But those have only about 10% of patients actually converted to a response when more immunotherapy was added in. So we're very strong proponents of ipi-nivo, but there's definitely a patient group in whom with very rapidly growing disease, then IO-TKI is the best option. But second line treatment, if you look at the Cancer Drugs Fund, you can actually use just about any TKI as second line.
Sure.
So I didn't really mention the lines of treatment. So we'd go for IO-TKI first line, and then with for second line treatment, lenvatinib everolimus is very good, very effective. But then you can't have used len-pem, obviously, first line, because you've used up your lenvatinib, but we now have access to cabo-nivo. With cabozantinib, a fantastic drug, you can use it at any line, essentially. Whereas with lenvatinib, everolimus, you can only use it as after one previous TKI. So you just have to play the game and position your treatment in patients in whom you think are going to go on to more lines of treatment.
Sure. Yeah. Thank you very much. That's very fantastic. Any questions from audience? Right, and one question's come up. So thank you for discussion, and would always do head staging and CD head or MRI head. what is your opinion on cytoreductive surgery after good response to first-line treatment? And is there a survival benefit?
Yeah, super. Great questions. So I didn't have time to cover absolutely everything, obviously. So yes, we're now always doing CT heads. I think if the contrast enhanced CT head is normal, we wouldn't normally do an MRI as part of normal staging. Obviously, if the patient's got a suspicious lesion, then you do an MRI. We've started, because brain mets can come at any time, we've started doing it sort of once, a couple of times a year in patients. We haven't got a strict protocol, but you do sort of unexpectedly develop brain mets, particularly in patients on immunotherapy can sort of develop brain mets without you realizing. So and because the reason why it's important to scan people is now that our treatment for brain mets is so much better. So if you can get them early and get them small, then SRS is a fantastic treatment, and they'll now treat sort of several lesions. But it's really important to know that, which is why we're now sort of routinely scanning people, because those patients can have like really long-term remissions, and nobody likes whole brain radiotherapy. It's absolutely horrible. So if you find them small, you can treat them. So cytoreductive surgery after a good response to first-line treatment, is there a survival benefit? We don't know. Trials haven't been done. In reality, what we're doing in patients who have had a very good response and have still got quite a lot of, quite a big renal mass, but potentially a complete response or near CR in other parts of the body, then yes, we are now sending selected patients for cytoreductive nephrectomy. There are no trials that I know of that are ongoing. Obviously, it was something that traditionally people did use cytoreductive nephrectomy when our systemic treatment wasn't as good, and there's no doubt that in the early days of interferon that improved the overall survival by doing a cytoreductive nephrectomy. But I think it's a very much in the air thing at the moment. My personal feeling is that if you start off with a very large tumor and relatively small metastatic disease and you're going for a good response, then in a fit patient, I would definitely advocate nephrectomy. If they've got a small primary to start with and have responded really, really well, they're probably not going to benefit that much. But you do find people still with a substantial tumor have probably got active cancer, which is going to keep metastasizing. So that's the group of patients where I'd advocate it. But it's very much a matter of controversy and opinion.
Thank you very much, and that's a very fantastic talk. It's very fascinating, and I learned a lot from the webinar.
Lovely. Thanks very much.
Thank you. Have a lovely evening.